Thank you very much. When looking at KC and its treatment, there are really 4 distinct types of things that you should be looking at regarding the treatment. Glasses and contact lenses, ways to reshape and make the cornea that you have optically more efficient, corneal transplants, and one of the important things in KC is that it's a progressive problem. One can get it in their teens, and it can get worse as time goes on. I always liken it when talking to patients as a thin spot on a tire or a balloon. As the cornea becomes either thinner or weaker, there is a tendency for it to start to bulge out because it no longer can retain the solid dome-like configuration that biomechanically it would normally have. And if you have that thin spot on a tire or a balloon, the tendency is, as you keep driving on it, for it to bulge even more. So one of the real important aspects of KC is its progression, and one of the, and probably the most profound therapeutic alternative to be discovered in the past decade is collagen crosslinking. Now, Dr. Chang discussed how keratoconus inherently is a biomechanical problem. It's a problem of corneal structure, corneal microarchitecture, and the strength of the cornea to retain its clear dome-like configuration. You can think of the cornea somewhat as a bridge. Its superstructure is that of collagen, and collagen is a helical molecule. So it's almost like a band of wires that support the bridge. These collagen helices, which are wrapped one upon another, are then linked together molecularly. So there are molecular bonds that link the collagen superstructure together, so you get these broad cable-like bands that make up the biochemical and biomechanical architecture of the cornea. These fibrils then come together to form lamellar pancakes. Lamellae is simply a pancake. So you can picture the cornea as being stacks of collagen pancakes, about 250 of them all told, such that the final thickness of the cornea from front to back is about 500 microns, which is half a millimeter, which is a well less than a 32nd of an inch in thickness. In KC, that superstructure, these collagen fibers, the lamellae or pancakes of collagen, are diminished in their architectural structure and their biomechanical strength, so they can start to bow out. Given that the inherent cause of KC is a lack of corneal strength, the question arose, if you can strengthen the cornea in some way, can we diminish keratoconic progression? It's now about 17 years ago that the concept of corneal collagen crosslinking was introduced. It was first discovered, so to speak, in Dresden, Germany, in Dr. Theo Seiler's laboratory, where they were looking at corneal structure and corneal biomechanic strengthening. So the first study said that the aim of this study was to investigate the possibility of the induction of crosslinks in corneal tissue in order to increase the stiffness as a basis for future conservative treatment of keratoconus, ectasia being thinning of the cornea a la keratoconus. How do we do this? Ultraviolet light inherently is a cross-linking agent. It's the reason you get wrinkles in your skin if you get a lot of ultraviolet light exposure. So if you've grown up, holding the aluminum foil and greasing up in olive oil in front of the sun, you tend to get more wrinkled as you become older. That's because the skin in your cornea, on your face becomes cross-linked, and it becomes cross-linked and more rigid and tighter, and those tightenings become the wrinkles that you get. Riboflavin, which is vitamin B2, is a photochemically active compound. That is, it interacts with light. It absorbs ultraviolet light to become activated, so it encourages the effect of the light on cross-linking of collagen. So what happens in cross-linking is that we use riboflavin on your cornea to act as a photoactivating compound, and we then activate it with ultraviolet light. Well, when the two of these interact, here is the ultraviolet light and the riboflavin molecule, a number of photochemical processes occur. In short, what happens is there is a photochemical reaction within the collagen lamellae of your cornea that cause cross-linking within the cornea. These may be between the collagen fibers, or within the collagen fibers, or between the collagen fibers and the sugars that make up your cornea. But what they in effect do is, by adding cross-links, it's like adding extra wires to a suspension bridge to make the bridge stronger. By making the cornea stronger, the goal is to keep your keratoconus from getting worse. And this indeed works. So this is out of Germany again. This is the earliest trial in the laboratory. And what you see is a cornea here, not cross-linked, and a cornea right after cross-linking, and it becomes more rigid. In fact, it becomes more rigid by about a fourfold, about 400%. So there is a substantial amount of corneal strengthening from the corneal cross-linking procedure. How do we do this clinically? The first thing is, in most cases, is the surface cells of your cornea, which are like the tiles on the floor, are removed. And this facilitates the absorption of the riboflavin, as we'll move on to the so-called epi-off technique. In the standard treatment, you get riboflavin drops every 2 minutes for 30 minutes to make your cornea nice and green. Here's the cornea in cross-section, and you can see that it's saturated with riboflavin. You then look up at an ultraviolet light like this, and the ultraviolet light then interacts with the riboflavin in the cornea to form the crosslinks. The crosslinks essentially are immediately made at that point. So the whole procedure is about an hour. At the end of the treatment, a contact lens Band-Aid is applied. This facilitates healing and makes you more comfortable. And then you use an antibiotic drop and a corticosteroid anti-inflammatory drop for a couple of weeks. It takes about 5 days for the cells to heal in, and the contact lens is removed in around 5 days typically. So does it work? How does it work? What results can you expect? So when thinking about cross-linking, for your own particular situation, you need to know the answers to the question. Is what can you expect clinically? What's it going to do for you? What's it going to be like having it done? What's the time course? How is it going to be for you after the treatment? And for an individual patient, we want to know as doctors, who is best to treat, who's best not to treat. As a measurable indicator of keratoconus, we look at your corneal topography map. And on that, we have something called the keratometry. The keratometry, kera means cornea, metry is measurement, measures how high and how steep your keratoconus. So we have a number called Kmax, which is the steepest or the highest part of the keratoconus cone. Average keratometry, if you ever hear the numbers, is about 40 to 47. So if somebody comes in, just a normal patient with a 49 cornea, that's a potential indicator for keratoconus. It gets back to the question answered just before. Keratoconus itself is somewhat difficult to diagnose, and one of the early indicators that the eye doctor can see is the K reading that they get when doing the measurements is high, indicating a higher than normal cornea. So when we're looking at cross-linking, we're looking at the height of the cornea and seeing over time, does it change? Typically in KC, it will tend to slowly get worse over time. So we're looking, does it get worse, stay the same, or get better? Well, to make a long story short, it gets better. So on average, after treatment with collagen cross-linking, looking at 205 patients who were in the clinical trial, on average, there was a slight improvement in the corneal topography, a slight improvement in the cone. And this kind of acts as an indicator that clearly we're slowing progression of keratoconus by doing the cross-linking procedure, because we compare this to untreated patients, and over the course of the year, they tend to get a little worse. So tendency of KC, on average, is to get higher cones over time. Tendency of cross-linking is to stabilize the cone. Here you can see one patient where the cone started at 64, and down here it's about 58 a year later. So you can see a generalized improvement in the corneal topography. When looking at these maps, and you probably have seen these in your own cases, these are color maps. This is like looking at a mountain range from a satellite. So a high point, a mountain, Mount Everest, is going to be red. A lake down below is going to be blue. And a fine slope is going to be green. And green is the color of a normal cornea, so to speak. So the less red you are in keratoconus, the less severe is the KC. And we see generally, after collagen cross-linking, a stabilization over time. There's somewhat of a healing process. In general, people get a little worse for the first few weeks as the healing is going on and vision becomes a little more blurry, and then you get improvement over the course of the first 6 months. We typically say all the healing is done from 6 months to 1 year afterwards. If we specifically look at your corneal topography, that is these color maps, in general, on average, they improve a little bit. So that's, again, a good sign that we're having a beneficial effect of the cross-linking. And then if we take it one step further and look at actually the optical static of your cornea. So this is like putting a computer on your TV, saying how high definition is the TV. So if we look at different kinds of static, we see a slight improvement after cross-linking compared to a slight worsening if someone's not cross-linked. So in general, cross-linking will help to stabilize the cornea, and on average will also improve the corneal optics a little bit. But importantly here is it's just a little bit. It's really not meant to affect your vision much. It's meant to decrease progression as time goes on. Looking at vision outcomes, both your vision without anything as well as vision with glasses does tend to improve on average a tiny bit. Again, this is just about one line when you're looking at the vision chart. An important thing to see here again in the healing process, you get a little worse early on just because there's a little cloudiness in the early weeks after the cross-linking. Then you get improvement over the next 6 months in general. In our patients, we administered visual satisfaction charts before and after the procedure. Asking a bunch of questions: how's your reading, how's your driving, do you get glare, do you get double vision? And again, in general, in cross-linking, there's a slight improvement. So these are before and afters. Lower bars are better than higher bars. So night driving improved a little bit. Glare, halo, starburst, all those kinds of things that the keratoconus patient tends to note. So a generalized improvement. Again, this is a mild improvement, but a little bit of an improvement. Now, you will notice in cross-linking that vision can become a little hazy early on. These are cross-sections of the cornea, and top and bottom are clear. So we're clear to start, clear in a year, but there's a little bit of haziness, which is the cross-linking reaction that we note. And you yourself might note some haziness in the vision over the first few months of healing. It tends to be its worst over the first few weeks, plateaus, and then goes back to your baseline clarity at the end of a year. This is, again, because of the cross-linking reaction. There are changes to the front parts of the cornea. The cross-links, again, between the collagen and the collagen glycosaminoglycans. So there's this wound healing process that will affect your clinical course after the treatment. Now, recollect that keratoconus is a corneal thinning disorder, and corneas are measured in microns. A normal cornea is 535 microns, plus or minus 35 microns. So within about 470 to 610 microns, those are considered generally pretty normal. Corneas are thinner in keratoconus, and the group that we looked at, average was 434 compared to the average of 535 that we see in ostensibly normal corneas. Now, you do see a little thinning after the cross-linking procedure, and oftentimes patients will be concerned because they'll say, hey, my number was 440 to start, it's now 420, I have KC, isn't that worse? Well, in fact, it's not. Again, remember, KC is like having a bunch of pancakes stacked on each other. So use as an analogy a magazine, which has a number of pages stacked on one another. Put some Elmer's glue between each of the pages, put an anvil on it overnight, lift it up the next day, and what are you going to find? You're going to find that your magazine, because it's been smooshed together, so to speak, is thinner, but it's stiffer. So the cornea can be, on measurement, a little thinner after cross-linking, but it's stronger. Another reason that you might notice some early worsening during the healing are the surface epithelial cells. In KC, if you look between here and here on a cross-section of the cornea, the surface cells, again, the cells being like the tiles on a floor, tend to build up over the thinner areas of the cornea. So in the early stages of healing, the underlying cone, what's really your cone, can be more unmasked. And it's the healing process that again covers it up and improves the vision afterwards. The next issue is, should everybody have it cross-linking done? Are there some people who are going to fail the procedure? Are there some people who are going to do better with the procedure? So we looked at about 100 patients and wanted to find, are there incoming factors that you have? Doesn't matter if you're a man or a woman, doesn't matter how old you are, doesn't matter how big your cone is to start. Are these things going to let us differentiate between who's going to do well with cross-linking and who's going to do poorly? When you look at individual patients, though, if you take these couple hundred patients, the average is an improvement, what you find is this. 1/3 of patients actually improve their cone by a substantial and meaningful amount clinically. Most of the rest remain stable, which again is the goal of cross-linking, but there are a few patients who continue progression afterwards, about 3%. So if you look at this overall, cross-linking works in about 95% of patients to slow or stop the progression. There's still some progression in 3.5% to 5%. So we want to see, are there patients where we might be able to predict who does really well and who might fall into that group. And one thing that we did find was, from the point of view of getting better, people who had worse keratoconus tended to get better, more better than if you had less keratoconus. So for people who had flatter cones, that they weren't that severe, about 87% remained stable and 13% improved a lot. In patients who had worse cones, about 55% remained stable and almost a half improved a lot. We wanted to see, are there indicators of people who might get worse? Well, if we look at just a little bit of getting worse, that is what we call a diopter or more, there was no difference. So we didn't find anything in a particular patient who would indicate that they wouldn't do well with the procedure. If we look at vision, we see a similar kind of outcome pattern. On average, people improve a little bit afterwards. But if you look at it in individual patients, about a quarter of patients get substantially better with their glasses. Rest remain the same, and again, about 3.5% worsen afterwards. And curiously, these are not the same people who continued their KC progression. We found that eyes and people who had worse vision had a greater tendency to get better with their glasses corrected vision. So 43% of patients who had poorer vision got 2 lines or better on the chart. Only 11% who had really good vision got 2 lines or better. More importantly, we wanted to look at who might get worse with cross-linking. We didn't find any actual indicators that you might not be a good candidate and you might get worse. However, there was a little suggestion that people who have really, really good vision to start have a slightly increased risk of just losing 1 line on the chart. So though they may be stabilized and protected against progression and worsening vision down the line, people with very, very good vision could be at a little risk of losing a little bit initially. Another thing we found was it mattered how big your cone was and where the cone was located. So people who had steep central cones on their corneal topography map tended to improve more than people whose keratoconus cones were way down inferiorly. So in your particular case, with cross-linking, it's important. You have to define the goal. What are we looking for? Mostly we're looking to stabilize the keratoconic process. We want to avoid losing vision, obviously, but in some people we might do this just to improve the corneal surface and corneal topography. So right now we're looking to develop what we call a corneal treatment algorithm, so we can kind of plug this into the computer and tell doctors, hey, when you come in, this is the kind of patient to treat, this is the kind of person who can watch and wait, and this is the kind of person not to treat. Now, what are some of the side effects and complications? There was a big U.S. multi-center clinical trial of cross-linking. This is the one that's currently working its way through the FDA. And we looked at 512 patients who were treated. There is a risk in cross-linking of a corneal infection. The frequency has recently been reported as 13 in about 2,700 patients treated, so about 0.5%. But there is a risk, though low, of infection, so you need to be followed carefully afterwards. In patients who have had a particular kind of viral infection, herpetic, corneal infections, this might be somebody who we would not choose to treat with cross-linking because it has been shown to potentially be reactivated by the cross-linking procedure. So it's something we want to carefully evaluate if you have had herpetic keratitis beforehand. There are rare cases of corneal scarring after cross-linking, particularly in high degrees of correction with thinner corneas, and it can cause a picture like this, which if it's right where you're looking out can affect your vision substantially, but often it is to the side, fortunately to the side of the vision, and doesn't have a lot of visual effect. But these are some of the problems that can occur. There, in the early days of cross-linking, was some concern about the effect of the internal cells of the cornea, the endothelial cells, and the potential for swelling of the cornea. And this has been reported again in a few cases, but in the U.S. multi-center clinical trial out of 512 eyes, there were no incidents of corneal edema or swelling. The concern here is that the riboflavin reaction could affect the internal cells of the cornea. So we looked at this in particular. Normal corneas have about 2,000 cells in them, and there was no difference over the time course of the treatment comparing patients who were treated with cross-linking and those who were not treated with cross-linking. So let's quickly look at some new trends in cross-linking. We'll discuss a little bit more about cross-linking later on as well. The first is accelerated cross-linking. A number of you, I think, have undergone this at our clinical trial. Essentially, if we use ultraviolet light sources that nowadays can be made more powerful and more homogeneous, we can decrease the treatment time. So we've decreased in some of our studies treatment time from 30 minutes down to 3 or 4 minutes. We've also found that oxygen from the air is important in the cross-linking effect. If depleted, cross-linking effect is less. If there's more oxygen, the cross-linking effect can be made more. So we've done some work in some clinical trials with what we call pulsed cross-linking, where the light is on for a short time, then light's off, allowing replenishment of air into the cornea, then the light is on again. And this has been shown to give even greater strengthening of the cornea afterwards. So these are some of the things that we might see develop as cross-linking continues to progress. The big question that always comes up in any discussion of cross-linking is what you've heard about epi-on versus epi-off techniques. And this is a misprint. This is epi-on we're going to discuss rather than what we just talked about, which was the standard treatment of epithelial off. So transepithelial cross-linking, the otherwise known as epi-on cross-linking, doesn't do the first step that I talked about. We don't remove the surface cells, we leave them on. So we leave the tiles on the floor. Now, the potential advantage of this is that by not removing the surface cells, they don't have to grow back. So there is a faster recovery and greater comfort and less risk of corneal infection, though that risk is low in standard cross-linking. The disadvantage is its relative efficacy. That is, it is difficult to have the riboflavin soak through the cornea using an epi-on technique. The surface epithelial cells can actually block some of the incoming ultraviolet light, which can diminish the amount of cross-linking that you get. Because the epithelial cells act as a barrier to air and oxygen diffusion, as you just saw, oxygen is important in the cross-linking reaction. There might not be as much oxygen, hence less of an effect. And also, there are wound healing effects because you're not going as deeply into the cornea. There may be changes in the ultimate healing effects that would affect the outcome. So we have an ongoing trial looking at epi-on cross-linking. These are just some early treatments that we did. Number one, we do find that the time to soak your cornea is longer. So it takes about an hour to get an appropriate saturation of riboflavin into your cornea. So a little more boring for you to get the riboflavin in. To make a long story short, what we found is that in the short term, we see stabilization of the keratoconus. We see a little bit of improvement. This improvement is not quite as much as we see in the standard epi-off technique. Similarly, with visual acuity, we see a slight improvement. And this is with glasses corrected vision, a similar kind of outcome. So though we're comparing apples to oranges, that is, those patients we have treated with epi-on and epi-off because they're different protocols and different patient groups, it still appears that for the most robust effect, the epi-off technique is preferred, but certainly the epi-on technique will give a cross-linking effect, and we have to really determine in an individual case which one is the best for you. Things that are being developed now are new riboflavin formulations that better soak into the cornea, the new ultraviolet sources, which have higher powers and higher effects, as well as different ways to get more air into the cornea to facilitate the cross-linking reaction. So cross-linking still is not FDA approved in the US. It still needs to be done under clinical trial protocols that are under both FDA and what we call Investigational Review Board guidance, but the approval process is well underway, and we hope to have some news on that in relatively short order. In the meantime, we have a number of clinical trials looking at many aspects of cross-linking and are currently enrolling patients in these clinical trials.